Hello, my name is Niall McKay and welcome to Living with PSC, a podcast about the rare disease of primary sclerosing cholangitis. Now, PSC causes the bile ducts inside and outside the liver to become scarred, narrowed and eventually blocked, and leads to liver cirrhosis. In this podcast, we aim to dispel some of the myths about the disease. I'm here today with Dr. David Goldberg, who's transplant hepatologist with the University of Miami Miller School of Medicine. Welcome, Dr. Goldberg.
Thank you so much. It's an honor to be here.
We're talking today about rejection and reoccurrence of PSC in patients. I just wondered if you'd like to give us an introduction to your area of study.
Yes, so I am a transplant hepatologist by training, and I do mainly clinical research. I'm really focusing a lot on chronic liver disease, but organ transplantation as it relates to who should be waitlisted, how we should prioritize patients on the wait list, and how we can predict outcomes among those who get transplanted, and really sort of how to best allocate a scarce resource of donor organs, but how to maximize outcomes of people who get those transplants.
It's kind of a bit of a conundrum, really, isn't it? Because I suppose the earlier people are transplanted in their disease, the better their outcomes. But because of the scarcity of livers, you're kept to transplanting the people who are sickest first.
Right. So it's a challenge. And sort of that's one of the things is sort of figuring out who to best transplant and when, because, to date, any transplanted organ has some shelf life, and obviously there are exceptions of 30, 40, 50-year survivors, but those are sort of rare. And, especially when you're talking like a disease like PSC that can recur in a sizable number of patients, you have to wait transplanting someone when they're at their fittest, if you will, versus knowing that once you transplant them, at some point that organ may get PSC again or develop complications. Because I think, while people see transplant as a cure for some diseases like PSC, it doesn't cure. But, getting a transplant beyond just the surgery itself is obviously not a benign thing. The medications that we give to prevent rejection have many complications. So I think there's that delicate balance of sort of when is the sweet spot to transplant someone, taking into account the fact that there are a limited number of organs.
And do you have an opinion on that? When is the sweet spot?
I mean, that's one of the grants that I'm working on. I mean, I do think, in the US and in most of the world that has deceased donor transplant programs, we transplant the sickest first.
And that's not to mention the MEL score is not an accurate representation of a PSC patient and how sick they are.
I think the other challenge, sort of as you bring up, is that we focus a lot on survival and sort of, living versus dying. At some point down the road, we won't have a shortage. We can use, xenotransplants or artificial transplants, but that is a ways away.
You're also working on predictive models of how well people can survive after transplant.
That is correct. And, we've developed some models. I mean, one of the challenges with any model is, one, you have the only data you can use are the data that are available to you. But the other thing is that there's already some selection in who gets a transplant. So you may not be able to be perfect, but I think one of the things is we don't necessarily have to, say, is person A versus person B can we always say who will live longer? We want to know is if we say person A and person B are going to live 10 years, is our model able to produce that? So not just developing models, but sort of changing how we approach and sort of judge them. Because ultimately, we want to be able to accurately predict how long someone will live and whether they will get good use out of that organ.
And I presume that rejection and reoccurrence are part of this thought.
It's interesting partially because the way we capture that in, transplant databases is not great. It's good, not great. It's not perfect. But we actually don't often think about that when we're talking about transplanting someone. We think about their survival globally. We don't actually often say, well, is this person, higher risk of rejection? Because oftentimes we can treat that and prevent it. So it's really sort of more their global survival, their medical comorbidities, how frail they are. And the sort of rejection piece doesn't always come in.
Just talking about rejection, because it's one of the things that we want to talk a little bit about today. There are different types of rejection, aren't there?
Yeah, and I think, the term rejection is sort of problematic because patients oftentimes hear rejection and they think the body is rejecting the organ, it's failing, you need a new transplant right away, which is actually not the case. It's the way I tell it to patients is rejection is like, the new neighbors are moving in and you're sort of feeling them out, getting along. You may have, bump heads on, your trees over their fence or things like that, but you're not sort of like, burning down their house, sort of getting rid of it. But the term is sort of scary. There's sort of, the rare sort of hyperacute rejection. You put the organ in and the body just rejects it, which really doesn't exist now with sort of blood typing and sort of double checking the donor recipient types. There's sort of acute rejection, and acute, while you think acute means sort of it happens short term, is also it's more of a pathological diagnosis. So you can get acute rejection a month after transplant or 5 years after transplant. Chronic rejection is sort of obviously, as the name implies, a chronic process that builds up over time. So if you get your first episode of rejection right away and you treat it, that's not going to get chronic rejection. I think one of the challenges, though, in sort of evaluating how often acute rejection happens and its impact is how you define it and what led to it. And what I mean is two things. So way back, when this, 20 years ago or more, centers would do protocol biopsies. So they would do liver biopsies every, 3 months, 1 year, 2 years, 3 years. And you may pick up sort of evidence of rejection on biopsy. So inflammatory cells, inflammation in a certain pattern that suggests rejection, but the patient has no clinical signs of it. Their lab tests are normal. Other tests are normal. So it may have, a histologic sort of on the microscope rejection, but not clinically relevant. That obviously is, you could argue, different than rejection, where someone comes into the hospital, their bilirubin is 10, they're yellow, their liver tests are in the hundreds to thousands. That's a different thing. But then also what leads to the rejection. So we know certain factors may increase the risk of rejection. Sort of you have a more sort of primed up immune system. So certain demographics, people with certain diseases, people with autoimmune diseases are more likely to have rejection. Usually younger people, and actually women are more likely. And there may be some racial differences as it relates to sort of compatibility. But someone who gets rejection, who's on their immunosuppression and things like that, is very different than someone who, stopped taking their medications or, lost their, is I guess more of an issue in the US, but lost their health insurance, can't get their medication, and they're rejecting. That's a very different process. But when we study rejection and its impact, we sort of lump it all together.
That's,
And that's why there's potentially unclear data about the impact of rejection. So there was a study back from, I'm looking at, 1998, sort of thought to be the seminal study that showed that rejection, when it happens, actually is not a bad outcome and doesn't impact long-term outcomes. Our group collaborated. I was sort of co-first author with a colleague, Josh Levitsky at Northwestern, said that in a more modern cohort, that an episode of rejection, increases your risk of graft failure, so the liver failing in the future. Very different results, different time periods, but also neither of them could assess why someone had rejection. And if someone is non-compliant, they don't take their meds and they get rejection, that's different than someone who maybe you were trying to lower their immunosuppression because of kidney disease. They had an episode of rejection, you go back up and it doesn't happen again.
yeah. And in fact, a little bit of rejection is a good thing early on, isn't it? It seems to calibrate the system or something.
So it depends. That's what the teaching had been for a while, based on those older studies. I'd argue I'm not sure if I'd say 100% if I agree. I think it's a balance, like anything. What is a little bit of rejection and what time period and what led to it.
I see. And just and sorry for asking you to do a bit of a science lesson here, but rejection really is the immune system, the T cells in the immune system recognizing that the liver is a foreign object in the body and trying to rectify that. And would that be correct?
Exactly.
With, say, for example, somebody with PSC or with an autoimmune disease, their immune systems would be probably a little more active than, say, your average Joe's immune system. So the average person's immune system would be less likely to recognize that it's a foreign object.
Exactly. Yeah. So, and we and others have published that certain autoimmune diseases like PSC patients have a higher risk of rejection. Sort of the teaching, again, is that an older white male with alcohol-associated liver disease is sort of the lowest risk of rejection because of their age, because of their sex, because of their sort of race, genetic ancestry, and because of their etiology of liver disease. And I think that's why immunosuppression, there's, I think, more of a push to recognize that it has to be tailored, and the patient's phenotype and risk for rejection and what it means should lead to differences in how much you immunosuppress someone after transplant.
This is sort of this is the balance. And I must say, I admire you guys doing these calculations because they're quite complex, aren't they? When you have a patient that's post-transplant and when they're, assessing exactly how much tacrolimus they need and exactly how much steroids that you need to back that up with, if you like. It's a lot of math, really, isn't it?
Yeah, and I think it's a lot of math, and I think it's sort of, somewhat also to the individual, but also clinician. We are very different. You can have the same patient managed by two different doctors, and their immunosuppression, after the initial period may be very different. Some may feel like, okay, we could tolerate maybe an episode of rejection because we want to minimize immunosuppression because it could affect the kidneys, it could affect long-term cancer risk and cardiovascular, and others are sort of may give more immunosuppression to prevent rejection. I think that's the sort of art versus science of medicine, and how, because you can't do every trial to represent every patient, there is that sort of variability in how we practice, for better or for worse.
And is the ideal objective to reduce both immunosuppressants and steroids to as near zero as you can get and keep the patient healthy? Is that the gold standard, if you like?
So I think, we all want to get steroids off as soon as we can. I think there's, no doubt there's a lot of sort of bad side effects, and also having taken them myself, patients don't feel great on them. I think we always talk about sort of getting someone to the minimally acceptable level of immunosuppression, but what defines that, if someone, do you want someone's liver enzymes to be perfect? Can you take them a little elevated? And that's one of the challenges, is that they're being developed, but we don't have great biomarkers to know whether someone is having some low grade rejection. And we usually rely on their liver enzymes, which are not perfect. Your liver enzymes can be up for a whole host of reasons. They could also be normal and there's some low level rejection. And that's why there's a lot of work being done to get, better biomarkers, sort of better things to measure whether someone's having some rejection, because obviously doing a biopsy regularly is not, the best way to do it.
How does the immune system sort of come to accept the new liver over a time?
So, there's something called tolerance, where in essence, sort of, the medical term, but it's like, it learns to tolerate something that's foreign, your roommate, that they leave their dishes out and all. It bothers you early on, but over time you get to tolerate it, as long as it's not really, too bothersome or too, um, I guess, messy or too aggressive. You sort of learn to deal with it. I mean, I think that's a sort of simplistic way of thinking about it. It sort of learns to see it as one of their own.
I'm 3 months post-transplant, and hopefully I'll be 3 years and 30 years post-transplant. And if I was 30 years, well, 30 years would be good because I'm 57, but we'll take whatever we can get. But if you're, say, 20 years post-transplant, is your new liver more you, as in, does as the liver grows and regenerates, does it grow and regenerate with your cells or with the original liver cells?
No, it's with the original liver. So, but your body learns to accept it. So, as a way that sort of this was actually came up. I was texting with colleagues as it relates to your question. A patient develops cancer 2 years after transplant, and you actually want to know, is it de novo? Like, is it developing that cancer in that new liver, or is it some cancer that you had that spread to the liver? You can actually do tests, things called chimerism, to actually know, is it the donor or recipient. So, as one example, there are ways that certain sort of things that you can do that if your donor was a woman, an XX chromosome, and something developed a year from now in it, and they did studies on that tumor or whatever, and it was XX, you would know that it was a donor derived issue. So it's not that your new liver takes over your cells, it just learns to adjust to it. It doesn't see it as foreign over time, and that's why you have a lot of immunosuppression up front, because that's when it's like, wow, this is a foreign thing, we got to attack it, and over time your body learns to tolerate it.
Yeah, it's a fascinating science, isn't it? And
Yes.
and of course the liver, like we know the liver as cleaning blood, but it does everything, doesn't it? I mean, it does so many, regulating sleep. Like it has a huge function within the body, and possibly functions that we're not even aware of.
Right, and the liver it's a big immune cell as well. It helps with the immune system. So it sort of is intimately involved in so much. Obviously I'm biased, but I argue that, maybe after the brain is maybe the most important organ we have.
You have this acute rejection index to classify where somebody is. Can you explain that to me a little bit?
Yeah, so when they're sort of diagnosing rejection, there's sort of different patterns that you see. Certain cell types in certain locations in the liver that sort of determine if it's rejection, and then there's sort of the classification, and they're different. The Banff classification, I believe, because the meetings were actually in Banff, are used for different organs, for kidney, for liver, that are based on severity, both on the histologic findings, so how many inflammatory cells there are, where they are, but also clinically as well, because there can sometimes be a disconnect. Someone can come in, they're jaundiced, their bilirubin is really high, their liver tests are elevated, and you say mild histological rejection. Well, clinically, that's obviously not mild. So they're sort of, we look at the pathology, but you can't take that in a vacuum as well.
What role do clots play in blood clots, particularly hepatic ones?
One of the things, as it relates to PSC is, well, we know the disease can recur, and depending on where you read and what time period you're looking at, it can be obviously quite high. But in a transplanted liver, so in, my liver, I've not been transplanted, 80% of my blood supply feeding my liver is from the vein, and then a smaller amount from the artery. In a transplanted liver, it gets more blood supply from the artery. But even more so, the bile ducts are supplied by the hepatic artery. So if the hepatic artery gets a clot called hepatic artery thrombosis, or gets narrowed hepatic artery stenosis, the bile ducts can get damaged. So when we're talking about recurrent PSC or any disease that it's affecting the bile ducts, we have to make sure that the artery is not damaged, and that is the reason why the bile ducts are abnormal as opposed to some recurrent disease. But it's not related to rejection, but you can see, sort of microscopic inflammation, but the big clots that we worry about in the vessels, like the artery, we really think about as a cause of bile duct damage.
I see, and the bile duct then. The immune system tries to repair the bile duct, and then we're off to the races again with the sort of scarring, the sclerosing part again. Is that how it happens, or?
Yeah, yeah. I mean, Yes, it's inflammation, but I mean, it really is the issue of that, it's just they're damaged because they don't get their blood supply. So they just sort of, wither down. It's, a tree, you cut off one of the roots of it, it gets damaged.
I understand. And in terms of we have statistics for recurrence in PSC patients, which we think is about a third. Is that correct, or is that data outdated?
No, I think that's about correct. I think it's, there's been different reports. When we had looked at this in a sort of US cohort, we found about 20% at 5 years. In a Japanese cohort, they found 50%. There was a Norwegian group that had published that they found 25% around at 5 years, but then 50% at 10 years. Um, I think one of the challenges is obviously is sort of how you diagnose it and who's diagnosing it. Not that there's anything nefarious, but obviously the diagnosis of recurrent PSC obviously requires a bile duct damage, but also ruling out any other issue that could have caused it, which is vascular, which is a surgical, which is anything else. So, depending on how it's reported, let's just say someone had a bile leak after transplant, which happens, and then they had to get surgery to repair it. And then 2 years later, they get bile damage. Is that recurrent PSC? Is that a surgical complication? I think sometimes those things are sort of, gray areas, but I think it's fair to say the sort of 25 to 30% range. Again, there is some Norwegian data out there saying 50% at 5 years, at 10 years, but again, that hasn't been I haven't seen that yet in the US cohort. And I think that probably is a little high, but
Yeah, yeah. And then there might be, and would in the actual recurrence of PSC there seems to be increasing evidence that there's a sort of a leaching happening from the stomach, and is would that be the reason? Is the disease still, if you like, in the microbiome or in the small intestine and leaches over into the liver, or do we know?
I think we don't know. I think at this point it is really just hypotheses at best.
Yeah,
I don't think anyone really knows why it recurs.
I see. Yeah, yeah, yeah. And it's definitely, and of course, it's so difficult because you've also had stomach surgery. So,
Yeah, I mean, I don't think it's the stomach. I think the question is it sort of the microbiome? Is it, you know, that there's sort of the inherent immune cells there? I don't think we know. It's the same thing as like, you can treat someone for, early stage breast cancer as an example. They could be fine 5, 10 years down the road, it recurs. Why is that? Is it cells that are just laying dormant, right? Are patients with PSC having cells laying dormant that are ready to attack again? I don't think anyone knows. I think at this point it's just speculation as to why it recurs and why it only recurs in certain people.
and of course, it could have to do with lifestyle or food, or I don't know. Like it could be any one of 100 mitigating factors, couldn't there, that would encourage?
Yeah,
Yeah.
I think we don't know.
And in your experience, do you think we're any closer to figuring out a treatment or for PSC?
I think we are. Again, I'm not on the sort of the person sort of doing all these trials and things like that, but I will say at this PSC Partners meeting, sort of hearing about all these new trials on the horizon, it was um, very heartening to me. Um, again, but that is, I think that's sort of to be determined whether that's the case or not.
Because certainly, if we did find something for PSC, it would take pressure. Like that's what's been happening in recent years, isn't there? There's been decreasing pressure on the amount of livers because of, you know, um, the various cures that have come up for some of the other diseases, or PBC. People don't need to be transplanted quite as much as they used to be, and stuff like that.
Yes.
Yeah. Um, One of the things that seems to be common is that PSC patients are often repeatedly transplanted.
Exactly. I think the challenge there with PSC is always like, well, if I retransplant them, what am I going to do differently? I think that's a challenge, not just with PSC, but any disease that where the condition is recurring, but you don't know why and you don't have anything different to prevent it.
I see. What's the difference? It's just another question I have. What's the difference between, say, Prograf and Cellcept? Like, are they both it's the Prograf that's tacrolimus based, right?
Right. So there's different sort of classes of immunosuppression. So there's things that are called calcineurin inhibitors, sort of that's what they're inhibiting. That's cyclosporin. We don't really use much in Prograf or tacrolimus. There's then things that are called anti-metabolites, things that sort of inhibit the sort of precursors that make inflammatory cells. That those are things like Cellcept and azathioprine. Prednisone is in its own class, and then there's another class called mTOR inhibitors. There are medications that inhibited this mTOR, this sort of signaling pathway. Those are medications like sirolimus, everolimus. The backbone of immunosuppression that was really still standard is calcineurin inhibitors, tacrolimus, or the trade name is Prograf. But then that's one of the questions that come up. Most centers will give people obviously more immunosuppression up front. Two drugs, tacrolimus, prednisone, and oftentimes Cellcept. I think one of the questions in diseases like PSC or other autoimmune diseases is what do you do 1 year down the road? And there's variability. Some centers will just do one drug, tacrolimus. Some will do two because we think there's a higher risk of rejection. There's never been a formal study to say which is better. It's hard to do a head-to-head trial of that. And if you look at sort of, retrospective, so you look back, one of the challenges is, are people on two medications because the doctors think they're higher risk or because they had some episode of subclinical, very minor rejection, so they want to prevent another one?
I see. I see. So it seems that one of the big weaknesses, I know that PSC is a rare disease, but we're lacking a lot of data here, aren't we?
We are, and I think this is a challenge with any rare disease. Is there's maybe 500 to 600 transplants for PSC every year. A subset of those are people with bile duct cancer, but otherwise they're sort of spotty as to this center does 20, this does 30, this does 10. You can't necessarily study that without a multi-center study. But obviously then the question becomes is who's going to fund that multi-center study, because I think there are many key questions to answer. But with orphan diseases like this, it's, well, how are you going to study it and who's going to pay for it? I think one of the reasons that the Norwegians, and I say that the researchers in Norway have really sort of been leading the way in transplantation and studying it, is that one, there's only one liver transplant center in the country for about 5 to 6 million people. So you don't need multi-center data. You have it all there. And two, as I understand, they was a grateful patient that to the transplant center there has gotten a sizable endowment to study PSC, including transplantation. So it has one center and someone who's able to fund it. In the U.S., we have multiple different centers, and if anyone on this podcast is interested in studying PSC and transplant in the U.S., you know, the funding is the other arm we need.
Yes, yeah. No, very, very much so. I mean, it's helped with the Chan Zuckerberg has helped enormously in the rare diseases network, but we're still on our
Absolutely,
way.
and I think like any disease, the PSC Partners has had a focus first on the disease itself pre-transplant, which makes sense because that's where the bulk of the patients are. But sort of the transplant patients oftentimes are sort of orphans in an orphan disease because essentially all clinical trials, or almost all, will exclude such patients. So like they don't even have access to the new therapies that are being tested. So,
I see. Yeah, yeah. Yeah, because it would skew the study essentially, because they'd be higher risk, I suppose.
Right.
So it might, I can
Right.
see it.
I guess my daughter's name is Madeline, but like the Madeline storybook, right? The transplant recipients are the Madeline of, the orphanage where they are.
Yeah. I can see how it goes. Um, the is there anything I haven't asked you that you want to add?
I would say though that, if you're a transplant recipient with PSC, while the disease may recur in a large subset, I think it's obviously natural to then sort of key in on, oh my God, when is this going to happen? When's the other shoe going to drop? But I think on the flip side, majority of people won't get recurrent PSC. Overall, transplant recipients with PSC do as well, if not better, than most diseases. So while it may not be a cure in everyone, it does give you your life back, and I think it's easy for me to say to, don't worry about it recurring, but I think that's a key thing, because I think sometimes you've been through so much and you're like, oh no, I may get this again. And yes, unfortunately you might, but you also might not.
Well, great. You've been so helpful. Thank you so much, Dr. Goldberg. This has been very, very useful. And thank you very much for your service with PSC Partners as well. We appreciate that too.
All right. Thank you. I appreciate it.
Well, I'm afraid that's all the time we have for this week. For more information about PSC and for a list of people and topics we'll be covering in the near future, please go to www.pscpartners.org. That's www.pscpartners.org. PSC Partners is a non-profit organisation dedicated to providing education and support to primary sclerosing cholangitis patients. There is information and resources on the website. There is a conference once a year. There is a private Facebook group that you can also join. Also, please join our patient registry. This is an anonymous database that provides research support to the medical community who are researching this disease. Thank you very much for listening.